This session follows on from the two earlier ones that were focusing on the technical detail of what SNOMED hopes to achieve, what it's for, how to use it. But I've had a long-term interest in what do people actually do with these coding schemes that we give them. What do people actually do with SNOMED as far as we can tell? And I thought I'd start by looking, in case this bit isn't something you often see, how the codes get into the record in the first place, especially in UK primary care. So there are a number of sort of different ways this can happen. On the left-hand side is a screenshot of, I think, TPP System 1. It's a clinical terms version 3 system under the bonnet, or was. And so their clinician may type some narrative text, which is not coded and not machine interpretable, at least it wasn't until recently. They may pick from a coding interface some individual codes. They may pick a code to describe what they've done, an intervention, and they may annotate that with some extra text. So there's a mixture of codes plus text in that field. The record that they review may have, for this is an example of a section on current sensitivities and allergies. Some systems I've seen have natural language processing, so they might begin to take the narrative text that the clinician had typed, typing mistakes and weird acronyms and all, and from that generate candidate codings. So these might not be picked by the normal coding thing. There isn't a lot of stuff I've seen of voice to text to code so far, but you might imagine that there might be research on that. But it's interesting that that's not a very common modality of just capturing voice, transcribing it to text, and then using the existing text process to generate codes. But all of those bits of their record could be given a SNOMED code. Another modality for putting code, and this is increasingly common, is to use assessment forms. So these are handcrafted, sometimes by the supplier of the system, and then cascaded out to the many clinical sites. So they all use the same assessment form. In many cases, there's a lot of local crafting going on of these things in response to local needs. And that's certainly also the case in secondary care settings, where for the most part, they don't get a very rich list of pre-authored, off-the-shelf structured forms. There's a lot of configuration that goes on in writing these things in-house at each individual trust, often slightly differently. Obviously, they're doing the same medicine, so you would expect the forms about the same things to be broadly the same, but they're not authored the same. And critically, the codes they're bound to underneath all of this may not be the same. So here you've got a form for assessing somebody with asthma. There's a list of forms that you could use on the left-hand side, and how you find the right one of those is an interesting question. But having found the form to assess somebody with asthma, the right-hand side sort of breaks down the sort of things you might want to say. It's general metrics of what's their body weight, standing height, body mass index. Do they smoke? Have you given them advice to stop smoking? How is their asthma being managed? Are they under the care of a physician? Have they had an emergency admission since you last saw them? Are they using a spacer? Have they showed you how well they're using their inhaler? Or did they decline to tell you how well or show you how well they're using their inhaler? And so on. But under the bonnet, although the clinician that fills these in, most of what you see there can be and often is coded to a SNOMED code, or before SNOMED came along, to one of its precursor coding schemes. And so every time you click on one of those buttons or enter a value, then what actually gets persisted into clinical record may very well be pairs of SNOMED codes, or a code plus a value. And so clinicians have been, started off 20, 30 years ago, mostly putting in a lot of narrative text and maybe one diagnostic code to summarize that particular 10-minute consultation. As time has gone by, more and more they're using structured templates like this, partly so that they can hit the maximum quality and outcome framework score points. There's a metric that of all your patients whom you have given the diagnosis of asthma to, how many of them have you measured their peak flow in surgery in the last 12 months? And if you hit the right percentage, then you get some brownie points and some cash. So trying to make sure they maximize their income has gradually led to an increase in the use of these structured templates. And then when they look at the record, sorry, this is a bit blurry, but that's the original blown up very big. When they're reviewing the patient, there's obviously a lot of richness in the record that could be displayed. And so there's a certain amount of filtering that goes on based both on the date and the type of information, and what gets presented in what order on the screen may be partly code driven. So it's a kind of form of passive artificial intelligence support of how do I filter the totality of the record to present you with a meaningful view of what's probably going on today. And again, underneath the bonnet, there will often be a lot of SNOMED codes that are being rendered to screen as they look at what the status of the patient is last time they were seen and so forth. A very large part of GP records and also hospital records is, of course, the investigations and their results. So if this is now EMIS, the second of the two systems that predominantly have most of the market in UK primary care. So if you ask for investigations, you get this screen, and you can see a bunch of blood tests and the dates they were taken on the left, and those will all be SNOMED coded as to exactly what that test or result actually is, and then the numeric that comes with is just a numeric. And as you can see, if you're an EMIS, you will sometimes get a pop-up box at the bottom right of your screen reminding you that in order to maximize your QOF score, you need to do some tests, probably some monitoring that hasn't happened so far in this patient. So it's a lot of code-driven practice. So that's kind of a whistle-stop tour of how the data is being entered, sort of broadly speaking, today in UK primary care settings across the land. And so what is the result of them having poured the data in over the last 20, maybe 30 or so years since primary care became substantially paperless? And so this has been one of my hobby horses for a long time. And at the moment, we are quite lucky in partly because we've only got 2 suppliers. And they are required once per year to submit a single report that lists all the SNOMED codes that have been used at least once within their estate in the last 12 months, plus a count of how many times each code had been used to add a new electronic patient record entry anywhere within their estate. And also a practice count, so how many patients and how many practices submitted this data. And that allows us to produce some interesting graphs, beginning with, well, okay, so what's the overall trend in total volumes? If I add up all the codes that are used, the total uses, what do I get? The left-hand graph is a cumulative size of the lake, if you like. So in 2011, far left, in that first year, there was about 2.5 billion coded items added in that year. When you add in the total of the next year, where slightly more codes were added, you've got a slightly bigger lake, and so the lake grows and grows over time. But you can see it's not a straight line, so it's exponential. There's slightly more data year on year, and so that nowadays the quantity of data being added, new codes added per year, is about 2 or 3 times what it was when this exercise started. But the figure on the left-hand side, interesting, is that you can't really see an obvious pandemic effect. The line just seems to keep on going with barely a glitch. If you divide the data by the number of patients, so now you plot the number of new codes added per patient per year, on the right-hand side, you get a more obvious, so hang on, something did happen in 2019, 2020. There was a definite dip, and we sort of took a little while to recover, but we appear to be back on trend as of kind of last 12 months. So I set out to sort of get this coded data, the usage data, to try and answer a number of questions. One of them was, from our side, we've got this enormous volume of codes that never seems to stop growing. And we know it's not perfect. So if we're going to have some kind of quality assurance or quality improvement exercise to review existing SNOMED content and improve it, where should we focus our efforts? And so one purpose of the code usage data, in fact, probably the original purpose, was to work out which bits of the coding system were actually being used, and therefore where quality improvement might have the most useful effect. A secondary part of that was when we were looking at assuring the data migration maps, when we were looking to say we've got all this data that has been historically coded not using SNOMED, but using something similar, either read version 2 or clinical terms version 3. And now we want to map all that historical data over to SNOMED. There are a lot of maps to be reviewed. So do we really have to do them all, or can we target our efforts? So again, we kind of use the code usage data to target those codes that we knew were responsible for most of the record, and that's significantly less than all the codes, as we'll see. Again, in terms of content improvement, both by us and by SNOMED International, who of course look after the greater part of the codes that are available, there are constant refactoring exercises to improve the coding system by them as well. And they're interested to know when they're thinking of killing off what looks like an innocuous code, they often use the code usage data to confirm that that particular code is indeed either not used at all or not sufficient to be worried about. So again, that's another use in the QA quality improvement area. I've always been interested in sort of widespread miscoding. So is it possible from that kind of aggregated national level data to identify patterns of worrying misuse of codes, and to use that to liaise with suppliers and so forth. Another potential use of the code usage data is when people didn't know which codes were being used and which codes were not being used, but they were asked to craft data extract specifications for complicated bits of medicine, like find me all the codes that indicate the patient is immunocompromised, for example. An awful lot of time can be spent wondering whether code A should or should not be clinically in the list. If you happen to know that code A is not in the data because no one ever uses it, you can cut short that argument and move on quickly. And so increasingly the code usage data is used by people in that industry who are crafting code extract specifications to inform their decision about whether to worry about certain codes. And sometimes it'll also say, we definitely found the right code, we're asking the right question, but no one's putting the data in, so I'm not going to get a reliable answer, even though my question is perfectly sound. I just happen to know nobody puts this data in. So care.data, QoF themselves, and cohorting as a service are all using the the code usage data in that context. I've kind of had an interest in what are the predictors of subsequent usage. And I'll show you in a little bit one of the slightly interesting ones, which is impact of the term length. But if we can kind of predict what is it about a code that makes it loved or unloved as time goes by, could we use that to provide better guidance to people who keep requesting new codes? The other thing you can see in the code usage data, obviously, is the effectiveness of any kind of coding directive to change coding or put more burden of coding on GPs. So, for example, the Home Office were particularly keen and remain particularly keen to involve GPs in policing gun license issues. But if you look at the coding data usage, by and large, although there are codes around to say eligible for gun license or license declined or whatever, they're not used at the sort of level that suggests they're being used accurately. So whatever the Home Office might want, GPs are basically too busy to do it. And lastly, in the absence of coding directives that are instructing or trying to motivate change in how codes are used or which ones are used, are there in fact codes where code usage appears to be changing, but we don't know why? And how common is that problem? So when we get all this code usage data from the suppliers, one of the things that leaps out straight away is that there is clearly coding drift going on. We know that we now know usage changes over time. So this graph on the right-hand side is plotting a number of things. If you focus on the light blue line, first of all, towards the top, what that is saying is that if you look at the most popular 1,000 codes in any one year, they will collectively account for about 87% of the entire coded payload. But if you look at the set of 1,000 codes in 1 year and those in the year afterwards, you'll find there is only about a 95% overlap. About 5% of the codes are no longer as loved. But as you move your two data sets further and further apart, the overlap reduces. So if you take data that was recorded 10 years apart, although in both cases there will be a set of 1,000 codes that accounts for 87% of the data, only about 80% of the codes are the same. So there's about 20% difference in how that data is being recorded 10 years later, and it's a slow drift. If you look at the top 5,000 codes, which is the slightly darker blue line, it's the same shift, or even the very dark blue line, the top 10,000 codes, which is 99% of all data. It's not the same 10,000 codes from 1 year to the next, and over time it gets further and further apart. And there's even higher levels of churn if you take out the top 1,000, which maybe the top 50 are fairly stable over time. It's the same top 50, but as you get down towards the 800th, 900th most popular codes, they seem to have a bit of churn. If you look at the codes between top 3,000 and 5,000, that's the very bottom line. So these are not that common in any 1 year. There's very little overlap. Less than half of them are the same 10 years on. So there's quite a lot of coding drift going on. If we assume the medicine has not fundamentally changed in that 10 years, then the way people choose to talk about it, the codes they use to describe what's in front of them, is clearly drifting over time. So I mentioned that sort of 1,000 codes accounts for 87%. This is a plot of the percentage, so the cumulative EPR items on the left-hand side by, I just remember how this is here. So it's all the SNOMED codes that are used at least once, listed from left to right, and how many times they're used on the vertical axis. And this is actually the plot. What you can see at the very far left is a very thin blue line, which is the most popular code of them all, which manages about 180 million uses per year. But after that, code usage drops dramatically. So if I change the left-hand scale to a log scale, we can see rather more clearly that common things are incredibly common, but everything after the sort of first 1,000 codes is pretty rare by comparison, and getting rapidly rarer. So there's a very steep Zipf distribution of code usage. At the bottom is a list of the most popular codes. So it's no great surprise to see blood pressures as the numbers 2, 3, and 4. And serum creatinine, measure of kidney function, is the 5th one down. Patient's phone number is the 6th one, and then we've got some more blood test results. So by far and away the most common test result, as most commonly selected codes, are results. And in fact, of that big data lake that I sort of summarized earlier on, about 40% of all of it is pathology results, blood test results predominantly. So only about 60% is diagnostic and procedure data. The number one most popular code, with just over 1.8 billion in code uses, is I sent a short message service text message to the patient. It doesn't even say what it's about. It's I've sent an SMS. I'm not entirely sure what value there is in having quite that quantity of data in the clinical record. I think it might be used for billing, but as a payload in the performing now, what about 1/20th of the entire lake of data is a code that says I've sent a text message to the patient, but not what it is. So there's a lot of sort of slight noise in the data in there at the moment that's going in. By way of giving you the steepness of the Zipf curve, there's about 2 codes that have used more than 500 million times in total in the last 12 years. 78 used more than 100 million times. At the bottom, 45,000 used more than 10 times, but less than 100 times. I think each of those are bands rather than total width. So 50% of the entire GP data is accounted for by just 82 codes, 85% by just over 1,000 codes, and 99.93% of the entire GP data payload is within 40,000 codes. So that gives you an idea of just how steep the curve is. So what else did we learn from studying? What have I learned from studying this data? So here's one interesting insight. This grey histogram is the number of codes in SNOMED that have a preferred term of a certain number of characters, including spaces. So the peak, which is around 30-35 characters, says that one of the most common lengths is a relatively short code of only 30-35 characters. About 20% of all SNOMED codes have a preferred term that is over 80 characters. So that's what's available. This is what's actually used with that SMS sent message, the big red spike, sort of outlier at about 60 characters in length. So with the IFA, I think it's sort of shifted slightly to the left, but certainly the longer codes, unless they have a very snappy acronym, HbA1c, hemoglobin A1, or COVID vaccine is up, although that's a very short synonym, if you will. It sits out of this length here because in actual SNOMED it's fully spelt out as coronavirus vaccination and all the rest of it. So those bars on the right hand side are outliers because they're more commonly accessed using much shorter synonyms. So there seems to be a preference for relatively short descriptions in what UK GPs put in. In hospital, much smaller data set. So that GP, the red histogram, is based on just over 9 billion coded items added in the last 3 years. The blue histogram is a report of 5.5 million coded items added in 2 hospitals over a longer period of time. But again, they seem to avoid the longer SNOMED codes. They prefer short, snappy phrases. And that may well be a consequence of the user interfaces that they're given to pick the SNOMED codes. But in secondary care in particular, there's very little constraint or guidance on what SNOMED codes you enter. And so here are some choice examples of miscoding of patient diagnoses for inpatients in 2 London trusts. So you've got patient with a spot who got this code for a freshwater eastern seaboard fish with a spot on the side, which is why it's known as a spot. Here you've got a patient with a mole. Here we've got one with a corn on their foot, but the code they've actually put in is for this. Here's a patient with thrush, who's been given a code for a garden bird. Here's a patient with a fairly common and self-limiting and not that exciting fungal skin disease, pityriasis versicolor, who's been given the code for a multicolored duck. Here's a variant of the same thing, just pityriasis, which is this, slight thickening of the skin, where they've picked a code which actually corresponds to a tropical bird. Shingleback, I'm guessing, is a typo or some variant looking for shingles on the patient's back, possibly. What they've actually picked is this interesting lizard, and so on and so forth. Here's a sty of the eye, which is hordeolum, and they've picked Hordeum vulgare, which is the species barley. So there's a fair amount of miscoding that's going on, and some of it is not necessarily clinically trivial. That's in secondary care. You might wonder, how is it that the system is allowing them to put codes which are obviously for organisms into a slot which is expecting a diagnosis? So the clinical systems could do better, but at the moment there are no levers to pull to persuade them to do better. But even in primary care, where the systems are considerably more constrained, there are miscoding patterns that you can see. So exudate in a primary care setting probably more likely means that the patient, when you look into their eyes with an ophthalmoscope, has evidence of a sort of a fatty stuff exuding from the blood vessels at the back of the eye, which is a symptom of hypertension. What they've actually, in 71,000 cases, put in 1 year, that is a code for just a substance. It's not a diagnosis, it's not a clinical finding. Very unclear what that means. Next one down, drinks, probably means euphemism for they're an alcoholic. But what putting the code drinks into a patient record means as a substance. That's the common parent of water, amongst other things. And last one down, 1600 uses of the code for human coronavirus, which is the parent of, in SNOMED's taxonomy, all coronaviridae, including those that cause a common cold. We might guess that they mean COVID, but that's not what they put in. So that's a near miss, but it affects counting of stuff. And that might be all in one practice. So they may have it's not like evenly spread out across the country. So the other thing I was interested in more recently is changing coding behaviours, and I kind of showed you the coding drift problem, and this is kind of trying to understand the sort of 12 years of data. So sorry, it's on autopilot. So we've got 12 data sets, and within those data sets, it'll tell us what the usage of an individual SNOMED code was, and so you might get one time series for one code and a slightly different shaped time series for another code. And if you look at the individual codes within individual systems, the first thing we see is some interesting differences in how bits of SNOMED are used. So the top left-hand graph we'll start with is a chart of how often any of the codes for a viral disease of any kind at all collectively were entered year on year in our two clinical GP systems. So you've got about 74 million code entries between those two systems over 12 years that say the patient's got some kind of viral disease, and that could be anything from shingles to a viral lower respiratory tract infection. All of those are being counted. Rabies, the whole Monty, are being counted in those lines. And the first thing to say is that the red line is in most of these graphs plotted on the right-hand axes. And so we can see that the absolute numbers are broadly the same. So the top of the right-hand axis is 9 million per year, and the left hand is 10 million per year. So they're broadly the same amounts, but the shapes of the curves are very different. Up until the pandemic, the red system was pretty static, which is sort of what medically you might expect, but the black system was going up and up and up for some reason and had sort of increased by 30% over 8 years. Both of them were affected by the pandemic, but one much more than the other. So what's going on? If we assume the medicine that these clinicians were seeing was broadly the same, why is it being described differently in the two systems? Middle graph at the top, liver function tests, much smaller set of codes, but you might expect those to be a very similar pattern, but they're not really. Again, you've got the red system being broadly flat over the 8 years pre-pandemic, but the black system very clearly increasing year on year for 8 years, and then a pandemic blip in both cases. But one has recovered back to trend and the other one hasn't. The codes for heart disease on the right-hand side, so it's not just that one code. In fact, it's that angina, heart attack, everything. Those are showing a more similar shape of curve over time. But very different sizes. So the right-hand axis tops out at 3 million. I think that's the red system. The black system is using the same set of codes, but about 3 times more frequently year on year. The trend is the same, but the absolute counts are different. And then every so often you get some very weird effects, the bottom row. So the codes for different flavors of self-mutilation. Not only do you have kind of diametrically mirror image patterns for the two systems, but one of them's got a massive spike that comes out of nowhere in 1 year and then disappears. And that's quite a common phenomenon to see these unaccountable huge spikes upwards or downwards. Things just drop out for a whole year and don't get recorded. So that's kind of system effect, which is kind of worrying. We don't understand why that's happening, what impact that might have when you aggregate the data across both systems, but are not aware that the data may all be coming from one. So I was kind of looking at these time series and thinking, well, can I use my A-level maths to sort them out? I'll replay that slide. It's all on autopilot, unfortunately. So when you superplot all the time series, you end up with this jumbled mess on the left-hand side. But I started using linear and quadratic regression and other not terribly sophisticated tools to try and sort them, to analyze the shape of the curve for each of these time series and sort them into those that were, broadly speaking, going up, going down, going over a hill or going through a valley kind of thing. And so if you take all the stable ones and then also standardize, rescale them so they all have the same mean, you can believe that although originally they were at different magnitudes, although running broadly stably, that we have indeed found a load of series that are, broadly speaking, going sideways with a bit of variability year on year. So this, for example, is how I tried to validate, was I getting the right results? This is 250 different time series. Some would have had a very high year-on-year magnitude, but flat. Others would have had a very low year-on-year magnitude, but flat. But they've all been rescaled to the same mean value, so they fit more on top of one another. But they've got a fair amount of variability, but we can still believe that overall they're all kind of trading sideways within a relatively narrow band. I can pick out those where the variance is much narrower and plot those as a set of 250 codes, which are, at this point, I have no idea whether there's a clinical correlation. All I know is that there's a mathematical similarity between the time trends of these codes. And so using that approach, I can kind of sort the 48-odd thousand SNOMED codes, which individually were used sufficiently to be able to use this kind of approach. And if a code was used once and once only 5 years ago and has 0 for every other year, I'm not really going to be able to use this technique. So in order to qualify for being fed into this sausage machine, they had to at least manage 1,000 uses over the full period of time. So what we're looking at here is the kind of 5 main patterns that I managed to identify, and I've chosen the time series where that fit reasonably closely to what I was looking for. So you've got 250 codes plotted one on top of the other at the top left, where they were all basically going neither up nor down. The next one down, they're all going up. And you can see that of the 48,000 codes or so that were analysed this way, a little over half of them are going up. And that kind of fits with the picture from much earlier, where we saw the size of the data lake is increasing year on year. The volume of data going in year on year is increasing. That's therefore not surprising that individual codes within the overall set of options available are mostly going upwards, but about a fifth are going downwards in a nice steady line over 12 years. That's the bottom left-hand falling one. There are also some that are going through the valley of despair or over the hill of optimism, which is clinically, if the medicine's the same, what's going on there? The sharp-eyed may have noticed, however, that all the graphs on screen at the moment are only up until the pandemic. So they cover the 8 years, 2011 to the end of 2018, middle of 2019. So if we take exactly the same time series that are showing now, but extend the graph to the right to include the pandemic period, we can see that the very well-established trends that had displayed themselves up until the pandemic, to a great extent, unravel as soon as the pandemic hits, and have not returned to their prior well-established trend. So there's clearly been a fairly seismic change in coding behaviours across the board since the pandemic in UK primary care, that we don't really understand what that means for anything much. And interestingly, HES data is perhaps not that dissimilar. So this is a plot of the 150 most common main diagnosis ICD codes reported in HES data, and they're listed in tiny font on the right-hand side. The big spike, the emergency use of U07.1, that's the code for COVID as a diagnosis that was first made available in 2020. It's no great surprise there's a massive spike and it's died off. The other codes, however, are kind of more mainstream medicine. So here we've got the code for a singleton born in pregnancy. Now, I know the fertility rate has been falling and is becoming slightly of concern in this country, but I'm not completely convinced that the number of patients, single children born in hospital over the last 12 years has reduced by 30-odd%. So is that actually accurate? I don't know. Incidence of urinary tract infection, site not specified, appears to have followed this orange line with a rather lumpy descent. So what happened to the treatment of UTIs in 2015, 2016 that meant it suddenly started reducing as opposed to the previous trend? Pretty much all of these show a massive dip during the pandemic year and variable recovery since. But from the 10,000 foot view, looking at the confusogram of plotting lots of time series one on top of the other, it looks very familiar. There's some massive changes. This blue line here suddenly disappears to basically not being used at all. So whatever we may already be used to handling the ICD data, bearing in mind whatever's going on over time as to how people describe medicine and what factors are at play to affect that. That phenomenon appears to be visible in HES, and it's certainly visible in GP data. So in the context of AI, which is, I self-confess I'm not at all an expert, I can pretend very much so. I'm looking for people to shoot all of this out of the sky also. That's very interesting. So a few musings on that topic, bearing in mind I'm guessing at least some on this call have an interest or maybe even are already significant practice that involves AI techniques. SNOMED embeddings, where you turn SNOMED codes into one-hot encodings or whatever in an AI tool, I believe are a required thing, and there are a few that are available off the shelf from people dealing with SNOMED International. You just need to know those won't be suitable for the UK because they won't include UK SNOMED codes in their embedding. And given that 40% of our UK data is coded using codes that are unique to the UK, if people are going to need embeddings, we're going to need to develop those that are specific to the UK. I don't know how to do that or who would tell us whether we got that right or whose job it is to make them. Also bear in mind that, again, in the UK, both of our primary care vendors are able to issue their own SNOMED codes in addition to those that come from the UK national release. And something like 5% of the EPR payload year on year is expressed using codes that are unique to one of the two GP systems, and we don't have a record of what they mean. They are purely commercial. We know that the raw clinical data is very sparse in the sense that although there are, in theory, 500,000 SNOMED codes, but maybe only 300,000 that you would ever expect to be in a record, of those 300,000, only 200,000 have ever been used in the last 12 years. So a significant part of SNOMED is just never used. And of the bit that is used, quite a lot of it is used only very marginally. So how do what's the best way to optimize analysis to take advantage of that sparse data set, but without throwing accidentally babies out with the bathwater? There are some AI researchers I know are developing approaches that will extract from this actual data that is coded across a large number of codes, but many of them used very sparingly, to a smaller number of classes. So exactly how do you do that in ways that are useful is a matter of research. The data quality issues I've kind of raised appear to be common and pervasive, both significant and serious clinical miscoding. I think in my earlier presentation I touched upon road traffic accident being miscoded as renal tubular acidosis, for example. So we know this is quite common. And we also know that even without that, that this sort of phenomenon of coding drift, where the same clinical phenomena appear to be being recorded slightly differently year on year, sometimes with clear trends, smoothly increasing over time for reasons we don't understand, or smoothly decreasing, but not always. Their magnitude and the clinical significance of the variations in coding drift is not constant across individual clinical domains. So that you need to be aware that this phenomenon exists and make some kind of assessment as to how badly it might affect the very specific clinical question that is being asked. And the discontinuity in both the long-term coding drift problem that we don't really understand, the miscoding problem that we don't really can't really quantify, and whatever has happened since the pandemic in terms of altered clinical coding behaviours may be a source of dragons in the context of training and using AI. And as I said, worst case would be if you chose to take an AI that was trained on GP data obtained up to 2020 and then expected it to perform equally accurately on data acquired after 2020, when all the evidence would suggest those are not the same anymore. We need to be aware of that kind of problem. And I think that's me.